golfing on a Monday. Welcome to Anesthesia Life. Why do I still pick the elective where I have to be here at like 6:30 to 6:45? So this is my anesthesia elective. This is not typically in the core rotation course, and I actually kind of got lucky to get this in my third year. Typically, it's super packed and really competitive to get into. Just it's first come, first serve on top of the lottery. And there's a lot of people that want to do anesthesia, and understandably. So I have 4 weeks here, most of it in general within the OR, and then a couple subspecialty rotations like OB, which I'm on right now, seeing epidurals and spinals, as well as acute pain, chronic pain, and the one that I'm most interested in, pediatrics. So the typical morning starts about like 6:30, 6:45, where I have to get here early to change to my OR scrubs. Then I'll meet with my attending and go over the anesthetic plans for all the cases in the rooms we're going over today. And then I'll go review up on my drugs using Amboss, take a look at some of the procedures that we're doing today so that when inevitably I get pimped, I'm super stellar. I'm going over all my pressors, and then especially today, reviewing up on epidurals and spinals for the OB side of things. After I review, I'll go meet my attending down in the PACU to go see the patients, talk to them, do our pre-op assessment, and get these cases going.
Basically, you want to run through a couple of safety checks on your anesthesia machine to be sure it's ready to go for the day. Literally tells you what to do for each one, and then press start, and it'll run through and you'll look for a pass sign. If there's any leaks or issues in the circuit, it'll alert you. The letter in our acronym is A for airway, and that's a pretty big and important setup, as you can imagine. You start with your laryngoscope, and you'll choose the size blade for your patient size. Use AT tube with stylet and syringe to inflate the balloon. You always want to make sure your balloon is not have a leak, and leave your syringe handy just so that when you intubate you'll have it right away. That you will choose that size for your patient as well. It's always nice if you have the option to have a standby video into the laryngoscope, and this is a McGrath that can assist you with intubation if you're having difficulty. So just checking to make sure that is charged and ready to go. Next, we have an oral airway with a tongue depressor, which can help if you need it with bad mask ventilation. We have a bite block, which we make here just by hand, and that's to prevent the patient from biting down on the tube and stopping all ventilation. So this can be placed right after intubation or just before extubation. The temp probe is not really airway, but it kind of is in the face generally, because we'll place it in the nose, sometimes in the armpit, and it just fits nicely to be on your tray here, ready to go. Nasal trumpet is another airway device that you can use to prevent obstruction if your patient has that problem, so just having that on standby is good. I also have some tegaderms here, which is to protect the eyes. So you want to, once your patient has been put to sleep, you want to put the tegaderm or tape on the eyes to prevent corneal abrasions. And then the last little piece is a heat and moisture exchanger, which you can hook into your circuit a little bit later after you've gotten everything settled, and that just prevents buildup of moisture and heat. I for IV, I always like to start setting up the IV with a clean and fresh bag of LR with the tubing attached and primed, ready to connect to an IV if we need it. An efficient IV placement, you have your standard kit with a tourniquet and a dressing, some needles of different gauges, your flush syringe, and some extra gauze just to have on hand. And then I like to have a roll of tape just to tape it up and secure it after it's released. Preparing the drugs is typically starts with just preparing some empty syringes and labeling them. It does take some time just opening and labeling, so go ahead and do that ahead of time, and then when you get your drugs you'll be able to draw them up more quickly. And it depends on the case which exact medications you'll be using. So this is what I have for my case today, but that obviously will change. And when I go to the pharmacy and pick up the drugs, then I will actually draw them up and prepare them ahead of time so that they're ready to go. And I also, if I have time, will prepare my syringes for the rest of the day if I know my cases, and just have those on standby. So.
Okay, so the past 4 weeks I've gotten a look inside kind of what goes on behind those drapes in the operating room. The days consisted of obviously being in the ORs for a long time, learning the skills of intubation, induction, and using Amboss to really learn all my drugs because, wow, I can't believe I forgot so many since first year. Of course, there's plenty of time for lectures, and we had a lot of our fellow students present at the national conference. And then one of my favorite parts of anesthesia is that there is a huge component of simulation education in there, which is interactive, to say the least. But I think a weird sensation I've gotten over these past 4 weeks is that as much as I've learned about the field and really appreciated what they do, as it's something that I was considering, I think something you guys need to know as medical students, future medical students, is that on your anesthesia rotation, I think you really should do it at a community center and not at an academic center. And here's why. At an academic center, the role of the medical student on the anesthesia side is little to none. Of course, you get your intubation practice, of course, you help prepare syringes and prepare the rooms, but there's just only so much that a med student can do because all the residents need their numbers. The CRNAs may or may not be inclined to teach you, and then honestly, I got a lot of airways taken away from me from paramedic students, CRNA students, and even dental students and ENT residents. All that to say, there's a lot of people learning at the exact same time, and I would be lying to say that I got as much as I wanted to out of this rotation, which is not necessarily a bad thing. I think it is the truth behind the anesthesia side at a lot of academic centers. Is this a fantastic field? Absolutely. Is it necessary? Definitely. Is it a lot of fun? I definitely think so. But is there room for improvement to help involve medical students and get them earlier or deeper exposure into the field? Yes. With that being said, it was really refreshing to have 4 weeks where I'm not exactly studying strictly for a test. It's just studying to make sure that I know what I'm doing in there, which is a nice change of pace and something that I rarely get to say nowadays in rotations. Of course, with the downtime, I was working with Amboss to use their Q-Bank to prepare for my days in the OR and prepare me for my next rotation, which, by the way, I think you might notice that this is not my room or typical Augusta setup because, well, this is a preview of where I'm gonna be for the next 3 weeks on orthopedic surgery. And yo, Tyler,
Yo.
you wanna say hi?
Hey. Have y'all bought freeze frame yet?
I don't know. Should they?
Yeah.